Good morning, everyone, and welcome to today's Regional Geriatric Rounds webinar. Today, Dr. Anne Harley will be presenting on hip fractures from the Ottawa Hospital to Bruyere Continuing Care. Dr. Anne Harley is an assistant professor in the Department of Family Medicine. She completed a year of training in care of the elderly at the University of Ottawa and has been actively involved in education of learners at all levels ever since. She has a focused care of the elderly practice on the Geriatric Rehabilitation Service at Bruyere Continuing Care, where she is also the Quality Improvement Lead. Welcome, Dr. Harley.
Thank you for the introduction. I'm joined as well today by Dr. French, who will be present for the questions at the end, and hopefully we'll have some interesting discussion. But it's really great to speak to this group today because I think you'll add some additional perspective on hip fractures and some of the challenges that these patients face navigating the system, because you share the same love of geriatric patients as we do, and we've intentionally left a lot of time for questions and discussion. We have nothing to disclose. So at a very simple level, the hip fracture initiative that we're talking about aims to increase the number of hip fracture patients who flow from the Ottawa Hospital Orthopedics Unit to Bruyere Continuing Care Geriatric Rehab on or before post-op day 6. And before you think this is simply a project about moving patients out of beds into other beds and flow, we'd like to convince you that this is a lot more about providing best practice for patients with hip fractures. And if there are changes to flow in the system, that's an important secondary benefit. I don't think this is a group that I need to impress upon the importance of the hip fracture on the health trajectory in someone's life. I like to think of hip fractures as a geriatric syndrome in and of themselves, and it's an opportunity to start looking for other geriatric syndromes that may have precipitated the fall or will have a significant impact on the person's ability to recover from their hip fracture. The statistics following hip fracture remain pretty grim. We know that there's significant rates of delirium on the orthopedic services, and this is not a criticism of our colleagues in orthopedics, but simply a recognition of how frail some of these patients are, how prone they are to developing delirium. There's quite a lot of disability following a hip fracture, and about half of patients will require a new aid permanently for walking. We still see high rates of patients following a hip fracture being placed in long-term care, and there's still a significant mortality risk at 1 year. So we spent some time looking at the research and the evidence that's out there as to how best patients recover from hip fractures. And certainly there's evidence to suggest that a combination of an environment in which patients undergo a comprehensive geriatric assessment and work with a multi-professional interdisciplinary team to receive high-intensity rehab has the best outcomes. And we're looking at pretty significant outcomes of change in a discharge location, so home versus long-term care, improved functional recovery, and better outcomes at 30 and 90 days. Just a few words about quality-based procedures, of which hip fracture is now one. These are identified by Health Quality Ontario as conditions or health events that we see commonly in the healthcare system, but that we see a lot of variability across the province. And they're an opportunity for us to share best practices and to drive better quality. So in general, a quality standard that's devised will have a panel of experts. They'll look at all the literature and they'll come up with some measurable quality statements. And the intent is really to improve quality, and they have a very broad definition of quality, may improve mortality, patient experience, functional status, and the intent is to see that bring the level up in all settings. So the hip fracture QPB was released in 2017, and they offer advice on the length of time people should wait for surgery, the type of procedures that should be done, and care in the immediate post-op period. But as well, they state that all patients following hip fracture should be offered rehabilitation. They feel that post-op day 6 or sooner is the start date for rehabilitation. And the program, they're quite prescriptive regarding what the program should consist of. And they outline it here. I'm sorry, there's a little bit of blurring of the slide, but basically it's a full assessment of people's ADLs, IADLs. So we're looking at not just, improved mobility, but balance, strength, and strengthening, nutritional assessment, fall prevention, modifying the environment, looking at pain medication and pain management, but also polypharmacy, thinking about an exercise program following discharge. And finally, Bruyere, we're doing the full geriatric workup. So looking at mood, cognition, delirium as well. So now zeroing in a bit more on what we see in Ottawa. Certainly before COVID, we were aware that the longer patients stay on a surgical service, the more impact this has on surgical wait times, and as well the more patients that a service will have admitted off service, so on a non-surgical service or another, rather than being on orthopedics, the patients are on the ENT service. With the arrival of COVID and the cancellation of a lot of surgeries, we now have a huge backlog of surgical cases to deal with. And as well, in spite of a lot of different quality improvement projects, the orthopedic lengths of stay, while the target may be post-op day 6, is still averaging around 9 to 10 for those patients who have been referred to rehab. And at the other end of town, we have geriatric rehab at Bruyere, where our standard of care is to offer CGA and high-intensity rehab. And we like to think of hip fractures as really one of our core businesses. These stats are from 2019-2020 fiscal year. And you can see that in that year, 33% of our total admissions were diagnosed with hip fractures. That probably undersells the numbers because sometimes we have them coded as something different. Because we know from looking at our data for many years that on average our hip fractures comprise about 40% of our admissions. We have a good track record with hip fractures, and we get a good percentage of them back to the community and are comparable to our peers across the province in terms of functional outcomes. And so we consider we do well with them. But paradoxically, there are times when we sit with empty beds and have the capacity to admit more patients when the Ottawa hospital's overbedded and sort of bursting at the seams. A final word on system integration, and this is really to talk about what may be coming in the future, where certain conditions are provided with what's called bundled care, or funded with bundled care. So there'll be funding that spans the continuum of a hip fracture scenario, which starts first with their presentation in the emerge and their operation, following through to 90 days post-surgery. And so it's really an opportunity and an indication that we're going to need to start collaborating more and more across all sectors of the healthcare system. And in this case, there's a natural partnership between acute care and subacute care in order to achieve the necessary metrics. The data here that I provided is from a larger table when we had a subacute care capacity report done in 2016 by the Hay Group. And it's just illustrative of how much variability there is between different LHINs in terms of patients being referred to rehab, patients being discharged to long-term care, to home. And so it can reflect all kinds of different things, the local population, the local resources, but it's worth understanding just the degree of variability. I'll let you gaze at this for a moment. And this is just my view of how things have changed over the years in terms of my own career and how we've dealt with referring hip fractures to geriatric rehab. And thematically, I guess we started very simply with individual physicians coming and doing a consult and making the determination, yes, this patient's for our program or no, to becoming more and more collaborative and grouping consults together with other services, and most notably geriatrics, and then physiatry, short-term rehab. And then there was the creation of the transition care coordinator, the subacute team, and gradually the physicians stepped away a bit from the assessment and were more remote, answering questions on the phone, to the extent that we've now come to a point where we're looking at having the physicians really less and less involved and trying to see how much of this can be automatized. So before I tell you our proposed plan, I'm going to tell you a little bit about the research that's informed how we got here. So we started with a pilot on ortho in 2017, 2018, where we thought that the clinical associate might be well positioned to identify patients who could come over earlier from the general. And as with many quality improvement projects, surprise, surprise, it didn't work quite as we anticipated. And although there was a lot of goodwill and determination, we still found we weren't increasing the numbers and we weren't getting patients over a lot sooner. So rather than just trying to continue with the same project, we decided to really understand the situation a little better. And we acknowledged that this was a huge quality improvement type of project in hiding. So the type of research we did was very different. We did what's called a barriers and facilitators analysis. So we took a framework called the TDF, and we used that to identify, it's a known methodology that looks at healthcare change in the system, and it helps to identify barriers and facilitators to implementing a change. And based on the results of that funding and that research, we've been able to design our automated pathway for hip fractures. And as well, it's given us a lot of indication of the areas that we need to focus in on in terms of some supporting quality improvement initiatives that look to launch and support this initiative. So the before scenario that we have been dealing with until recently was we have patients on the unit who've completed their surgery and they're sort of in limbo waiting for the timing to be right for subacute referral. And in that time, there's a lot of different professionals who are assessing the patient or providing their opinion to the patient. Patients and families also have preferences. So eventually determination is made that yes, this person might need to go to a rehabilitation bed, and then there's a referral made to subacute assessment team who then do their own assessment. So you can see there's a lot of clinicians and assessment involved. Our suggestion is to move to more of a blended, automated, I should say, process in which we have kind of a two-step process of inclusion and exclusion criteria. So in the first step, you simply early on in the patient stay apply inclusion and exclusion criteria, and then we continue to monitor the group who are included in the pathway to assess for when they're ready to be transferred over. So we've identified a dyad of 2 team members, the CCL and a subacute transition care coordinator, to gather the list. They will be pulling data directly from Epic each day to identify all the hip fractures. And then they will be discussing with the ortho team on a daily basis, could this patient be ready for transfer tomorrow? And what are the barriers or the next steps? So I'll show this more pictorially in a moment, but that's the overall concept. And at a more granular level, the inclusion criteria comprise of a unilateral hip fracture, age equal to or over 65, living in the community, and previously ambulatory with either a gait aid or without. We would be excluding patients who currently live in long-term care, are on hemodialysis or peritoneal dialysis, have a pathologic fracture, or are undergoing chemo and radiation. And then our definition of readiness to transfer is that they've had their surgery, their weight bearing is tolerated, their post-op day number 2 hemoglobin is over 70, consult services have signed off if they've been involved, and if there's a delirium that it's been identified and is resolving on the improvement trajectory. And of course, the patient consents to transfer. So here, I'll let you sort of envision what happens. So we have our fortunate patient who falls, who proceeds to the Ottawa hospital. And here you see somewhere early on in their stay, either as they're waiting for the surgery or immediately in the post-op period, the dyad arrives and they're pulled onto their list each morning, and they start to see if they meet inclusion-exclusion criteria. So it may be that a few don't, but this group is then followed along throughout their stay. So on post-op day 2, they start to think about readiness to transfer criteria, and some patients are again excluded, but many are just monitored and reviewed each day until they start to flow over because they've met our readiness criteria. And post-op day 6 is our target. I'm seeing the animation isn't moving on my slide. Is that the case in the presentation?
No, it's fine.
Okay, oh yeah, here we go. So I've overlaid some little bubbles here to indicate some of the areas where we've focused our attention on some quality improvement initiatives. One other thing I'd like to just add before we get to that is you'll see post-op day 6 is our target date, but certainly we can follow patients along a little longer than that if there's something, say they've been followed by an inpatient service, consult service, and everything's wrapping up and we now see that they're clearly ready for rehab. And this doesn't preclude a full transition care coordinator assessment if we think that's really needed at some stage. So just looking at some of the interventions, we identified through our barriers and facilitators assessment that patients and families need a lot more information about hip fractures. We want to create some materials that address frequently asked questions that will aid the team with obtaining consent for transfer, and also to provide patients and families with some, I think, realistic facts about recovery and trajectory after hip fracture and what's in store for them. So in terms of format, we're looking at creating an infographic that's very simple and pictorial regarding the pathway that will help both patients and families, but also team members. A video that patients can be shown about what rehab is like at Bruyere, and an accompanying handout. Another area that we want to look at is the dashboard. So I've alluded to a data pull from Epic each day, and this will generate a list that we can use to monitor the team's performance in terms of how many they're referring each month, how quickly post-op period patients are coming over. But it also allows us at Bruyere to be responsive when we have an idea of how many people may be potentially referred in the coming days. We can free up beds by making changes on our unit to allow for a quicker transfer over. It allows us also to, in real time, look back on the previous month, lean and adjust our criteria as we go along, and it can allow us to provide some quicker feedback as well to the ortho teams about how patients have been performing in rehab and whether that patient they were a bit concerned about how they've actually done. And so this is also something that we looked at in our research project. The transfer process is also being examined. We've trimmed our application process for the transition care coordinator so that the arm-in-arm form is much more abridged. We're looking at COVID testing timing because in the last few months that's been something that's prolonged their acute care stay, and always planning ahead for bed offers as well. We're looking at allocating a certain number of our beds on geriatric rehab as priority beds for hip fractures. So we're starting with 20 beds, that's just a guess, and we're seeing that we will offer hip fracture patients priority access to these beds. They'll be distributed throughout level 3 and 6 so that it gives us as much flexibility as possible to make bed offers on a prompt basis to our partners. And lastly, staff education is a big area. We know that at TOH we're asking people to do things differently. So there'll be some shifts in team roles regarding rehab decisions. There'll be a need to incorporate patient and family materials into the consent process, and obviously some input from that group of what they would like to see in those materials. And on a Bruyere side, we may have to adjust to patients coming over a little bit earlier in their stay, and a more diverse population of hip fractures, some who will leave early, others who will maybe take a while to warm up, as they say, and get ready for rehab. And we may need to strategize a bit more about off hours offering of therapy to patients. So as we work through this pathway, what we've noticed is there's a few areas that are sticking points still, where there's still a learning curve ongoing, and I've just highlighted them here. I'm sure they've already occurred to those of you who've studied them. And this is where we appreciate your input and insight. I think some of the advantages of the automated pathway are that it's inclusive. We won't be leaving patients behind. It allows for earlier identification of possible rehab candidates. Where it gets it wrong, it's easy for clinicians to override. Manually we can add anyone or take anyone off our list. If someone says they're from long-term care, but we find out, no, they're from a retirement home, we can change that very easily. We'll be offering much more consistent messages to patients and families, and allows us to study the problem with data behind us and data-informed decisions. There's still a little bit of ambiguity, obviously, around certain conditions, delirium, chemotherapy, and there's a big learning curve for the dyad because they really have a strong leadership, mentorship role. And certainly Dr. French and I realized that we're going to need to make ourselves available to help support that. So I think I've really touched mainly on the content of this slide, simply to say that we know we need to make some changes at Bruyere as well. We still have to work out repatriation to rural hospitals, where that fits into this whole process, what availability of rehab they have in different rural settings. And while the focus remains on discharge home, we do recognize that there will be patients who sometimes are just not able to make it there and may require different level of care. And so we certainly have outflow options available for patients. So just to sum up, the best practice seems to dictate that patients need both a combination of rehabilitation and comprehensive geriatric assessment. We'd like you to sort of shift your thinking to say that all patients who qualify could potentially flow to Bruyere, and the earlier transfer to rehab will help to maximize functional goals, and all stand to benefit. So thanks for your attention. And I think we're ready to entertain questions.
Thank you, Dr. Harley, for that excellent presentation. It's really innovative practices on improving patient care for sure. So if anyone has a question to ask, please raise your hand and we'll address you. We already have a question in the chat. Dr. Alan Wong asks, what percentage of the total cohort of hip fracture patients have a diagnosis of dementia?
I'll take that one, Veronique. I can see. I think that's hard to answer. I think it's high, but we don't see every hip fracture at Bruyere. We probably see a lot more of the ones with cognitive impairment. Maybe not to all extremes, but I think a good percentage of them do. And that's why we see such high delirium rates, and that's why we think that they do well in a setting where we can give them a little more time and help, if the diagnosis is new, help set up supports and really provide them with the time to adapt to some of the necessary changes that may be precipitated by the hip fracture.
Just to build on what Anne is saying, I think one of the things that we've seen over the last 4 years now that we've been working with ortho is how challenging it can be at times to actually be able to access the data that we need to really understand the population that we're serving. So there is some work going on in ortho right now, and I believe it's led by Steve Papp, but they're actually putting together a very large and detailed database around hip fractures. And I think that's going to allow all of us to have a lot more information about what this population looks like overall. As Anne said, I think we're probably getting a slightly skewed view just from where we sit at Bruyere, because we would typically get patients that are probably a little bit older, a little bit more frail, more likely to have had delirium in hospital. So I think that database that's being put together by ortho will be really key in really helping us understand what this population looks like overall. In terms of cognitive impairment and rehab from the perspective of hip fractures specifically, I think the other piece to just mention is that this is actually a population that's been studied in the literature and has been shown to actually do well in rehab. So certainly, you know, dementia is not a barrier to a good outcome on rehab, and I think we're seeing that more and more. The teams here have really seen an evolution that way in terms of the patients that come through. And I don't know, Anne, if there's anything else that you would add, but I would say overall, when a hip fracture is the issue, we do tend to see pretty good functional recovery, even with, you know, a fair degree of dementia.
Yeah, I would agree. And I think the other thing is that when we talk about, you know, best practice for delirium, and which we know dementia patients are at risk of getting following their surgery, our setting really does help to address a lot of the non-pharmacologic interventions that we usually recommend for delirium, like get people up for meals, get them dressed, get them focusing on daily routines, and things like that. So what you might see as a level of cognitive impairment in acute care can settle down, as I'm sure you are all aware. And after a week on rehab, we start to see a slightly different person.
Thank you so much to you both. There's a couple more questions that have come in. They seem to relate to each other. So Dr. Bashevsky asks, how do you deal with automatic referrals and delirium, agitation, and possibly needing sitters, or those who even have hypoactive delirium who may be missed? And the second part of that question, which relates, is there any cognitive impairment exclusions besides maybe delirium sitters, if that's the case?
Well, I think that that's, there's a couple things to address there. So first of all, we would say if they have a severe delirium, we would hope that the acute care team is taking a look at that. So if it's an unexplained delirium requiring, you know, one-to-one sitter and even medication, hopefully, you know, pneumonia has been ruled out, UTI is treating. But as soon as we start seeing the improving trend where they're getting better and there's a reasonable explanation for why the delirium accentuated, then I think we would be ready to accept those patients. I know we don't see all of the really acute delirious patients that you're seeing, so this is where we're interested in your perspectives as well. But I would say someone who can't follow any directions or participate, you know, can't follow one-step commands is of concern, and that is maybe someone that the transition care coordinator should do a full assessment on, rather than being part of this pathway. I don't know what you think, Veronique.
Yeah, I would agree with that. I think the biggest thing for us, as Anne was mentioning, I think, you know, some of the delirium management strategies that we know are effective around establishment of a routine, getting people up, washed, dressed, you know, eating their meals, sitting up, etc. I think a lot of that is just very much integrated into the structure of the program here. And so what's critical in acute care is to make sure that the underlying cause is understood as best as possible. And if there are investigations that need to be carried out that are only available in acute care, obviously it's really important for those to be completed. But that trend towards improvement is really the key. So we don't need the delirium to be fully resolved. We just need to have a sense of why this might have happened and sort of be working towards a positive trend on that front. Just to address Anna's second point around the hypoactive delirium, I think the other thing to keep in mind is, I mean, they are getting a very thorough assessment when they're here. There is sort of monitoring for delirium every shift here as part of the standard nursing practice as well. So I think, you know, we certainly do see some people that have an element of hypoactive delirium or have an element of certainly resolving delirium where delirium wasn't even necessarily flagged previously. And I would say that, you know, those things would be aggressively followed up and worked up here, and we would work through that on this end. So I think those were the points I would add, Anne.
Thank you to you both. I don't see more questions, but I have one just to add in here. So I was curious what the discharge destination is from rehab. Are the majority of the patients going home, or are they being referred to other services? And what's the average length of stay on rehab once they arrive there?
Well, we have a lot of data about those questions because we capture it quarterly, both for all our patients, but also based on their admitting diagnosis. So overall, in general, I would say our discharge back to the community rates, and community, we mean home or retirement home or a group home, is over 85%. And the remainder might go to another program. Some return to acute care, that's usually under 10%, somewhere around 7 to 9%. And then with hip fractures specifically, it varies a little bit. It's often a bit higher even. It's somewhere in the high 80s to 90s of percent discharged home. So generally that's our focus, is we are working to get people back to the community, and that's our primary intent.
I think the other piece to add to that was very interesting was in 2016 when the subacute review was undertaken in Champlain. One of the things that we were also able to see was that our discharge rates back to the community are sort of on par or maybe even slightly better than our provincial peers. But the patient population that we serve here is older. So on average, about 4 or 5 years older, and also tends to be more functionally impaired on admission. So again, I think it just kind of speaks to the importance of blending the high intensity rehabilitation with the comprehensive geriatric assessment, because I think the two pieces together are critical in terms of getting people home. Joanna, I know you asked about length of stay. So in terms of length of stay, these beds fall under the National Rehab Service. And so the way length of stay or target length of stay is calculated for those beds is based on diagnosis on admission and functional level on admission. And so those two things combine to give us a target. In general, for hip fractures, the majority of the patients are kind of looking at roughly a 4-week length of stay, so somewhere around 28 days. The people that come in that are moving better sort of earlier are going to have a shorter length of stay than that. But yeah, generally 3 to 4 weeks is what we tell people.
Thank you. We're going to move on to a raised hand here by Geraldine Dixon. If you want to unmute yourself and please ask your question. Thank you.
Hi, everybody. Thank you very much for this presentation. I have a question. coming from the medical field, doctor's office and stuff like that, what kind of information can you provide to us to hand out to the family members or somebody that's going in for a hip operation?
Well, we haven't designed it yet, but I think that there's a big need for that type of information. Looking at timelines of recovery, expectations for ongoing exercise and focused strength building, fall prevention. So our plan is to have our video for the patients at the Ottawa Hospital uploaded to our external infonet as well, so that can be accessed by patients out in the community or family members who are hearing about, my mom's in the hospital, they're talking about her going to Bruyere, what's this all about? Does that answer your question, or did you have?
Yeah, I think that answers my question. I think it would be wonderful too if if that information did get into our hands out there, and also too in the retirement homes, just because we do have a lot of questions that family members ask over the years that I've been in the medical field. They ask a lot of questions to, even the front staff as well as their doctors. So any kind of information that you can provide will be great. So, and I'd like to keep in contact with you, so when that does come out, that I can share that with the family doctors, if you don't mind.
That would be great. Thank you.
A couple more questions came in online, a clarification. So can sitters be actually arranged one-on-one if it's needed for some of those high intensive patients?
Yes, and we often look to familiar family members first and see what availability and whether we can strategize with them about the hours they do come, and how that will fit with our staffing. But we do have the opportunity to hire sitters if it's needed.
And another question from Dr. Molnar. So he writes, it may help trigger / encourage TOH planning to have an arm in diagrams for patients who do not qualify for Bruyere rehab. That could be labeled TOH rehab plan for patients who do not qualify for subacute rehab. I guess it's more of a comment.
So I think the one sort of point to make there is I think Anne's presentation this morning really focuses on this project that relates to the automated pathway, which is really aimed at making sure that sort of the straightforward hip fracture patients that are kind of behaving as we would expect them to post-operatively are really moved over quickly. And, in conversation with Carol Murphy from the subacute transition team, one of the things that we know is that, they are a scarce resource as well. And so we want to make sure that we utilize that scarce, valuable resource as effectively as possible. So if we can move patients on an automated pathway when they kind of meet these more straightforward inclusion-exclusion criteria, then what that means is the transition coordinators can really also then help us tease out what to do with those cases that are more complex or that don't meet these criteria. So if somebody doesn't meet this automated pathway kind of route, it doesn't mean that they're not going to come to rehab, but it means that they need a deeper dive before we figure out what the best plan is for them. And so I think that's just probably the thing to keep in mind in terms of what we're presenting this morning.
And in follow-up, does your team arrange for post-rehab cognitive follow-up in the Bruyere Day Hospital, i.e. if our consult team sees someone who has a cognitive impairment who is going to Bruyere, but we can leave it to Bruyere to arrange cognitive follow-up if you will see the patient as they are closer to baseline?
Absolutely. That's something we've worked on quite a bit, is handing off issues that we think would be better addressed in the community or down the road to our day hospital team. And they even have a process where they sometimes come and see the patient before they leave hospital to allow it to be, more of a familiar face. We'll take them down so they see the environment, the day hospital, before they leave the building. So yeah, we have good links with a lot of the community services. We also have the Bruyere Memory Clinic for people with more complex, challenging dementia presentations as well.
And another question here, how do you see the interaction between TOH Geriatric's consult service in cases of acutely ill patients?
We rely on you guys. You're our eyes and ears in acute care, and you have excellent assessment skills. So I think this is an area where there's room for more collaboration even within this project, to just say, you know, can you make sure that this person, if, based on your assessment, is earmarked for continuing to potentially be a rehab candidate while you're still working up the acute cause of delirium. And I mean, you guys can help advocate for ultimately these people needing rehab down the road.
And I would say there's no question that the geriatric medicine team at TOH are going to be the experts in terms of the acutely unwell geriatric patient. And so, of course, I think that you play a critical role in making sure that patients are medically stabilized. And that was part of the list of things that was covered on the readiness for transfer piece. So if somebody was still acutely unwell, then that would be something that would be required to be looked at before they're ready for transfer. And certainly we would envision, you know, that it would be highly likely that geriatric medicine consults would be involved in a scenario like that.
We have a couple of the last questions here. One, it says some of these patients might have secondary fractures that are not isolated just to the hip, i.e. wrist fractures. These individuals are usually non-weight bearing. Are they excluded from rehab?
Not excluded from rehab, but they don't fit this pathway. And we're trying to keep it simple intentionally, because when you start adding other diagnoses and exceptions, then it starts confusing everybody. My response would be that person needs to have a referral to the subacute team for assessment, and they'll sort out, you know, whether they need to convalesce somewhere for a few weeks while they have a cast, or whether there's someone who's already walking well with a gutter and walker and could actually come to rehab with that cast. So that's where we need their expert opinion and assessment. So it's not that they're not a rehab candidate, it's just maybe not yet.
Excellent. And the last comment here that I can see, has there been observations that different age cohorts, i.e. 65 to 74, 75 to 84, and 85 plus, follow different trajectories / complications?
I don't know that I have evidence at my fingertips. Intuitively, it sounds possible. I mean, the 65 to 75 people often have a lot of comorbid illnesses. They may have quite a burden of frailty, etc. So sometimes they're the higher complication rate than the 87-year-old lady who's had her first fall and fracture and was living alone quite well before then. So, I mean, one of the I think benefits of a system like this is just, as Veronique has spelled out, just the generation of data and the ability to really look at these age cohorts and follow them through and see how they do following rehab. And we'll have that data available if we get this up and running fairly soon.
So on that note, I want to thank both of you, Dr. Harley, Dr. French, for a wonderful presentation. And just a reminder for everyone, so please join us at our next regional rounds, which will occur Monday, June 7th at 8 a.m., where Kelly Kay from the Provincial Geriatrics Leadership Office will be presenting on Senior Friendly Caregiver Project.